Hi, everyone. I am Palaxani Combs, Program and Management Analyst for the DoD Medical Ethics Center. Welcome to our third panel discussion session. I will be your moderator. Today, again, we have our esteemed DMEC team of Mr. Joe Procaccino, our legal advisor for the DMEC and assistant professor at Uniformed Services University of the Health Sciences. Professor James Giordano, bioethicist for DMEC and professor at Georgetown University Medical Center. And Dr. Megan Applewhite, bioethicist for DMEC, director at the Alden March Bioethics Institute at Albany Medical College, as well as associate professor at Albany Medical College. Today, they will be addressing and discussing questions that have been submitted by our viewing audience. So let's begin. We're going to start off first with some questions about resource allocation. What is the role of an ethics service in terms of triaging and allocation of scarce resources during a pandemic? And how should an ethics committee advise commanders if called upon to weigh in on institutional ethics during such a time? Dr. Applewhite, would you like to take the lead on this question?
Sure, I'm happy to. I think ideally, given enough person power, bioethicists are integral in the carrying out and crafting of guidelines for resource allocation. Bioethicists have a unique viewpoint on resource allocation, as opposed to physicians who, although are expert craftsmen at resource allocation from day to day, when something shifts to a pandemic, such as we've recently had, physicians tend to think I have a patient in front of me and I'm going to do everything I can to take care of this one patient. Whereas when it shifts to a pandemic or, bigger demand on resources than maybe one patient can be considered for, you have to think about the greater good. And this is where bioethicists can come into play because really having a bird's eye view of sort of more of the utilitarian perspective or the perspective that the public health is paramount can be helpful rather than just only sticking with the patient-on-patient context that physicians tend to have. I think that having a bioethicist as part of the leadership team to help to craft the guidelines and to be a voice in the room is extremely important. That having been said, there's no world where the bioethicists should be the only ones crafting the guidelines and the only ones carrying out the recommendations on resource allocation, because there are a lot of practical components of allocation of scarce resources that bioethicists may not be the best people to help carry out. In taking care of the ventilator allocation guidelines at my own institution during the COVID pandemic, the hardest part wasn't even writing the guidelines. It was really thinking about how practically we were going to carry those guidelines out in the hospital. So, okay, we have our guidelines and everyone's getting their modified SOFA score and everyone is getting evaluated daily who's on a ventilator, who may need a ventilator to sort of determine who is the sickest and who may benefit the most from the support. But how does that information, how does that calculated score or assessment of each patient get communicated to a triage team to make that decision? We have to do it in an anonymous way because the triage team can't know who the patient is. They can't know if it's a man or a woman. They can't know the race. They can't know the ethnicity. It has to be a totally sort of third-party, blinded perspective that only incorporates how ill that patient is and how much they're likely to benefit from, say, in this case, a ventilator. So the most practical parts of implementing these guidelines were the most challenging ones to carry out. How do you communicate from the bedside to a blinded triage team? And that's where having more practical people who understand the workings of the hospital or the facility being part of the team is really important. IT ended up being really important. The critical care nurses being very important. The respiratory therapists being very important. The bioethicists were super, super important to have as members of the team. And it was interesting how talking with other bioethics program directors across the country, the way that bioethics was integrated in each hospital varied dramatically, all the way from being, in leadership in the incident command team, all the way to not even being asked to weigh in on any of the issues of resource allocation. And I think that depending on the institution, depending on the facility, there will be different amounts of person power available, but having someone who is trained and skilled in bioethics is certainly a valuable resource and necessary, I would argue, to be part of a resource allocation team in a pandemic. I think the initial needs of triage can be recognized at the moment, but ideally we have guidelines prepared well in advance that can be modified should a pandemic descend upon us again, and then we can then be more flexible and have our teams ready sooner. I think the sooner institutions recognize the value in bioethics and the fact that it can sort of be a third party to assess the bigger picture, the sooner they'll have success with rollout of these allocation guidelines.
Great, thank you. Mr. Procaccino, do you have a legal perspective on this question?
Well, I think that Dr. Applewhite really said it all from an ethical standpoint. Everything there is very practically stated. As you might expect, you can leave it to the lawyers and the law to kind of gum up the work sometimes here when we talk about allocation, particularly under the crisis standards of care, which sometimes may have to be put into place or implemented because of something like COVID-19. And when ethics committees and ethicists are thinking about triaging and looking at this kind of flip, if you will, that Dr. Applewhite talked about, from treating the most seriously ill first to trying to benefit the greatest good when you're dealing with a pandemic situation and an allocation of scarce resources, the questions then start opening up: whose vested interests are going to be met here? As we've seen with COVID-19, there are a veritable plethora of different interests that are involved. So you're going to be dealing, say, with indigent populations, with populations that may otherwise not get the same level normally of medical care. And how would that play out in a pandemic environment when you're talking with something that's going to further exacerbate the lack of care that they may be getting? You also have to take into account, for instance, religious preferences of individuals and individual hospitals and their willingness or not willingness to go along with allocation of scarce resources that may result in the death of someone who, under a quote-unquote normal circumstance, might be treated first. So all of these things weigh into the mix. And you can imagine then from a legal standpoint also, supposing you do have a pandemic situation like we have seen, and you find that a state or a region ends up setting guidelines for hospitals to use in creating allocation of scarce resource standards of care to use, so there's a sense of consistency. And let's say that your facility, for some of the reasons I just mentioned, chooses to deviate from those guidelines or standards that may have been set up. If someone ends up dying because they weren't, quote unquote, lucky enough to get onto the ventilator, and their family starts to sue the hospital for this, will the hospital be able to withstand that, saying that, no, they did not meet this kind of regional or state agreed policy, if you will, or set of guidelines, but they're going to have to be able to produce some kind of valid explanation as to why they didn't act consistently with other facilities and at least the community. So those are the kind of things that sometimes simply reality, the law, society will set up that has to compete sometimes with the ethical ideal that Dr. Applewhite has been talking about here. Over from me.
Great. Professor Giordano, do you have anything to add?
Oh, no, I think that my two colleagues handled that question very, very favorably from both the practical applications, that is to say in the clinic, and the underscoring legal applications would then substantiate medical decision-making.
Very good. Great. We'll move on to the next question then. During a pandemic or other times of limited resources within an MTF, how should military beneficiaries be prioritized? And we'll start with Professor Giordano on this one.
I've said before, and I'll reiterate again here, I mean, without any shame, realistically, the older mantra goes, good ethics make for good laws. The truth of the issue is that ethics makes for good conduct under the scope and tenor of the law. So here, there's a number of legal precedents that I think would be very useful, not only in guiding the clinician and or administrators. In this case, it's a hierarchy of command, but also governing how any such resources would be allocated. But let's back that up one step. If we're also going to look at the ethics that might undergird that, well, then there's an old ethical principle, which is called Prioritization, which is to extend the capabilities into the community or into the collective. So the idea of civic extensibility really applies when the collective is the military, and then next of kin, family, beneficiaries, become those individuals who then fall within the secondary availability of care. So how then do we balance this? How do we say the primacy of the patient's good, but then who becomes the patient? For the clinician, what we really see are three dynamic, interactive ethical principles. The first is the patient's good. And of course, we can look at the patient's good in a variety of different levels. The second is determining who will be that patient. Now, this is really a situation of patient and care allocation. So in other words, if in fact we think that any and all persons can be rendered into patienthood, then that looks at the clinician's act of profession to say any and all. However, the any and all nature of the clinical encounter and the act of medicine is also dictated by the auspices of the community or the collective in which that clinician is serving. In other words, if that act of medicine is to be a public as well as an individual good, then the rules and regulations that guide and govern that public or that polis are therefore applicable to the provision of those goods. Hence, the idea of extensibility into the civic domain, or perigere civitatis from the Latin, really has both an ethical concept and a legal construct that therefore allows its guidance and its governance. And for those legal perspectives, I hand the ball over and controls over to my colleague, Mr. Procaccino. Professor Procaccino, over to you, sir.
Well, citing the multilingua that you just used, Dr. Giordano, I would just simply say nihil dictum quod non dictum prius. Nothing is said which has not been said before. You very eloquently spouted the not only ethical but probably legal principles that are involved over here. One thing that comes to mind, I believe it's DOD Instruction 6003, which talks about the prioritization of active duty over other individuals, but doesn't speak to the issue of dependence. And the reason for that is somewhat obvious. We're talking about mission deployment requirement because we have a mission readiness type of mantra here that we have to prepare our folks to be able to defend the country, to be prepared to be deployed at any point. So there may be situations which are somewhat unique in a military environment where that population isn't going to end up possibly getting certain preferences for care over other individuals. That having been said, if we're honest with ourselves, particularly in a military environment, before COVID-19 ever struck us, there have always been these issues and questions of justice, if you will, within military facilities, healthcare facilities, as far as equal care for the population. And this has come into play quite often when we consider some of the questions raised about executive medicine or quote unquote the VIP wing in the hospital where a retired general or general spouse may end up getting a nicer room than somebody else or perhaps more direct care by a nursing staff than somebody else. And the question is raised, is that fair? Is that justice? Is that equitable care? And that's something that we do really have to look at. Now, again, you can make a very, very cogent argument that if you're talking about an active duty individual who's about to deploy, and maybe it's a 4-star general, that there may be a logical mission reason why that individual might get prioritization. But when you start looking away from mission requirements, then you have to start asking, what is the justification? And that becomes a problem. Over.
Dr. Applewhite, do you have anything to add?
Yeah, I'll just say one more thing, and I think the answers previously given were excellent. I think just sort of branching off of what Mr. Procaccino just said is when allocating these resources, we've run into a few interesting scenarios when sort of writing the guidelines. Some guidelines will imply that or make as a tiebreaker criteria, or even one of the defining criteria of whether or not you should be prioritized for a ventilator, as whether or not you're a healthcare provider. And this can sort of work from both sides, right? So the side that says that this shouldn't be the case is the side that says just because someone works in a hospital, it doesn't mean that their life is any more worthy of saving. It's not as if it's saying all first line responders. The person who's working at the grocery store arguably comes in contact with more people in less protected settings. The side that would argue that it is appropriate to take care of those, to prioritize those healthcare workers for ventilators would say, this is the idea that this person, if saved, would be able to come back and then save more lives, right? So if they are a person who is, say, a critical care nurse or a respiratory therapist or an intensive care doctor or someone who has the capabilities of saving lives and being, instrumental in taking care of patients within the pandemic, if we can get them better sooner, that's a multiplier effect, and we can save even more patients thereafter. And so saving this one person, then because they're a healthcare worker, then can be multiplied and save more lives. So it's just, it doesn't directly answer the question, but it's just kind of a spin-off of when do we prioritize those people. And in that sense, that even goes outside of the military, because what is the mission? The mission is to save the most lives within a pandemic setting, right? And so so there are many, many arguments that went on about whether or not healthcare workers should be prioritized in that way.
Great, thank you. This next question is primarily for Mr. Procaccino and Dr. Applewhite. What is the role of the Ethics Committee in addressing systemic healthcare disparities in a military treatment facility?
Well, as we said before, quite often the Ethics Committee, trying to act in an ideal fashion, pits itself in competition with certain rules and regulations, which may to some people seem inequitable. And this is a dilemma that's going to have to be worked out, probably with some element of compromise quite often. It goes back to the discussion we just had in the previous question as an example of, prioritization and whether or not such prioritization then creates some kind of feeling of inequity by other people that would be entitled to use the facility. This has come up as an example where, let's posit the following case, that you do know that there is a facility that has, by policy, a prioritization of active duty members, say for the use of the ventilators that Dr. Applewhite was talking about before, over other individuals, because they believe that those individuals have a stronger mission interest as far as DoD facilities are concerned. Or if you take it away from the pure mission issue, let's suppose that there's a prioritization, say, of people that don't have some kind of pre-existing physical condition. And there you start getting into questions involving civil rights violations and whether or not people that have disabilities are raising some certain legitimate concerns that they're being overlooked really because they have some kind of special need, even though they could contribute just as well to society. So the argument may go. And one question that's arisen from this is that should there be, as part of an informed consent rubric in a facility that is prioritizing, say, because of military need or because they're following a policy of preferring people that don't have pre-existing conditions in combination with other issues which may allow them to seek this prioritization, to say, hey, I happen to know that there is, say, as an example, a Catholic hospital that's 2 blocks down the road that is not following the same prioritization principle that we are here. And so if you have a choice of whether to go to that hospital or come to this hospital, the odds are you may get a higher priority of care at that facility as opposed to this facility. But should that be part of an informed consent process? And if it is, then how do you get that information to someone that hasn't gotten to the hospital yet or having to face this issue? It becomes a larger question, which I don't think was really fully answered during the COVID type of crisis that we had. But these disparities are out there, and certainly it is a role of the Ethics Committee to at least weigh these and decide what the population needs to know, how best to accommodate that population. Over.
Yeah, and I think one of and this can't happen, directly at a military training facility, but I would say one of the ways that we can sort of decrease these systemic healthcare disparities that have become so clear within the last year and a half is by educating medical students better and by educating our nursing students better, and just by further understanding what implicit bias is, by further understanding explicitly how it is that racism is ingrained within our healthcare structure as it is now, and doing everything we can to minimize it going forward, working it, gently massaging it, aggressively massaging it out of the system as much as we possibly can.
Great, very interesting. So that brings us to our last question for today. And this one we will start out with Dr. Applewhite can address this primarily. As individuals who take care of military service members and their families, how can we be respectful of certain unique cultural considerations while also respecting the needs of our providers caring for those patients? Dr. Applewhite?
Yeah, this is an excellent question. I think, one of the ways, that's maybe best to think about it is just to think about caring as patients on their level, that they're individual human beings, that everyone receives care differently. I think it's really important to end up saying that it's good to ask questions and to admit when you don't know things, and to say, tell me about how you best receive care. Tell me if there is anyone else who participates in your healthcare. This is a way that maybe you can elicit someone saying, oh yeah, I see an herbal doctor, or I see, a naturopathic doctor. And then you can better understand what other types of medications or interventions they're having that may actually interfere or, somehow play alongside your care. But listening and asking questions and admitting to them that you want to know about them as human beings and about their specific beliefs. What are their goals? What is it that they hope to achieve in their visit with you? One of the best things that physicians can do is listen to patients and be curious. Presuming to interrupt, presuming to know, or being afraid to ask questions, I think can become compromising for physicians. And if we would listen, and if we would just sit down and hear our patients and let them know that we want to know, and maybe we don't understand, but we wish to, I think that can go a really long way. And it is important to try to tailor care to respect patients' deeply held beliefs. But simultaneously, physicians do have the obligation to carry out the standard of care. And if there truly is a conflict of conscience and there is, a stumbling block at some point in care where a patient is requesting something that is out of bounds from the physician's position, there is an avenue to help that patient seek care with someone else, or to be able to seek consultation with another physician, and to try to respect that patient's values as much as possible within the standard of care and the standards of practice.
Mr. Procaccino, can you add to that?
It'd be difficult to top what was just said. I think I would only amend by noting that they're quite often, and I think this is fairly obvious to the audience that would be listening to this, that while we like to have them working together, quite often there is a conflict between autonomy, the ethic of autonomy, and the ethic of beneficence, because what the healthcare provider may believe is in the best interest of the patient may not necessarily be what the patient believes is in the best interest of the patient. And that goes back to what Dr. Applewhite was saying, that you need to try to accommodate the autonomy, the rights of that individual patient as much as you possibly can, because when you look at the balance, that really seems to take, at least in present society, a heavier weight. But you can't neglect the issue of beneficence. You can't neglect the standard of care that's taught to providers. And if there is a distinct conflict there, another good reason of the importance of an ethics committee to try to iron these types of issues out. But as has been said, when you're working in certain populations, for instance, Native Americans, there may be certain regulations or at least traditions in those cultures where informed consent is not necessarily given by the individual patient, but by the chief of that culture or tribe that may be involved, or other elder individuals. Have you gone to those? Have you explored those? Different kind of cultures have different types of traditions as far as not only informed consent, but end of life types of decisions, certain religious issues, and not only on the part of the patient, But again, we have seen the conflict using conscience clauses, not only for reproductive issues, but also for end-of-life issues with that ventilator, when you may have to actually remove someone from a ventilator who doesn't seem to be thriving with it to be able to be used for someone that has a better chance of thriving with that. And there are providers that would say, I simply can't contribute that way actively to the death of that individual. It's just beyond what I firmly believe. And so do you punish that individual? You really shouldn't be punishing that individual. They're entitled to their own religious or philosophical views. But then you also have to balance that with a limited number of staff. And if you have a large number of people that feel that way, how do you accommodate that to be able to accomplish the overall mission of trying to, as Dr. Applewhite said earlier, save, and Dr. Giordano said, the highest good to try to save the populace here. And that becomes a real dilemma quite often when you do have large numbers of providers that are really bucking what seems to be the best way to approach saving the most. So not an easy answer, but it goes back to the importance of communication, and ideally communication about these issues in a non-stress environment. So when things are going to happen, who is going to have questions, who's going to have qualms about this, how do you do workarounds, how do you cross-train, how do you accomplish the person to meet your mission to save the most possible while trying to protect the integrity of individual rights and preferences. Over. Dr. Giordano?
Oh, thank you. Well, I mean, if I can conclude what my colleagues have said, sort of bring it over the garden fence, so to speak, we can reground to the fundamental concepts of medicine. And this goes back to some of the prior work of George Engel. I mean, look, we're dealing with biological organisms who are embedded within whatever is their social framework, who react and respond to that social framework and to their biology psychologically. The biopsychosocial model is certainly not new. And if we appreciate that there is a multifold good for each and every individual patient that ranges from biomedical good, that really is the province of the clinician, extending to the good of the patient's choices, that good as a patient as a person, and then perhaps more broadly, the existential good that might be applicable to humanity. But humanity for that patient within their culture, each and all these have to be taken into the quasi-calculus of care. And what care means. I mean, in the literal sense, cura, to regard that individual, that person who was rendered to patienthood by some aspect of the human predicament of injury, disease, experience of illness, or just the changes that occur to our biology as a consequence of our lifespan. Well, that said, what we understand is that individuals develop in culture. The inextricability of that is fundamental. And this gets us to two more concepts of contemporary healthcare. One is called values-based medicine that has been advocated by Dr. K.W. Fulford, and the idea of goal-directed healthcare, been advocated by Drs. Victor Serpina and David Waters. In both, what they're suggesting very strongly is that to reground that patient to the reality of their circumstance is fundamental to a lot of what the clinician does. This, too, is certainly not new. It goes back to the older nosological method of Lord Sydenham. What is the patient presenting? How can I contextualize that to what I know about disease and pathology? And then how do I represent that within the context and realities of this patient in their world? Well, realistically, what that suggests to us is that many of the things that patients view, consider, regard, engage, or disengage as things that are salutary for their health, or in some way noxious, or in those ways that may be maladogenic, in other words, contributing to illness or disease or their feeling of unwell, are important to consider in the entirety of the clinical encounter. And as Dr. Applewhite has said, very often, a number of our patients will engage a variety of different healthcare modalities, and this is only expanded as a consequence of interculturality, inclusive of within the military and military dependence, the ubiquity and availability of information on the internet, and the ease and access of those various resources, services, and goods, once again, either direct to consumer or by virtue of various providers that may be available, both CONUS and OCONUS. So appreciating the reality, the entirety of that patient's world as a person and what that then means is an important step in the communication between clinician and patient, and also in rendering that multifold good that is so important, if not fundamental, to the regard or cura, care of that person. So I think the biopsychosocial model, incorporating those additional values, goals, and context, becomes very, very important and ever more important as we encounter an ever more global reach of not only our military medicine within the context of our military service members, but part of the outreach services that military medicine is bound to be providing on an international scale.
Great. Well, that concludes our session for today. I'd like to thank our panel members as well as our viewing audience for attending. Our next session will be another panel discussion of real-life scenarios, which promises to be very interesting. We hope you'll join us. See you then. Thank you.